Chairman, we are now live.
Good morning and welcome to this meeting of the West Berkshire Health and Wellbeing Board. I'm Councillor Alan McCrow and I'm Chairman of the Board. Before we start, I would like to explain for the benefit of members of the public who may be watching that today's meeting is being held in a hybrid format. We have a quorum of board members in the council chamber, with other board members and substitutes attending remotely. Members attending today include Councillor Heather Codling, Councillor Janine Lewis, Councillor David Marsh, Councillor Joe Stewart, Paul Coe, Anne-Marie Dobbs, Matthew Hensby, Jessica Jundu Evans, Detective Chief Inspector Emily Evans, Ned Whiteman, April Peverdy, Gary Paulson, Dr. Heike Veltman, Helen Williamson, Mike Faraday, and also in attendance we have to advise the board today Julie Dandridge, David Dean, Sanjay Desai, Rachel Peters, and sorry, I can't quite read this, Karuba Nagaratham. And we also have Hannah Elder from the Corn Exchange. Thank you. The meeting is being live streamed via YouTube, so members of the public are able to follow proceedings. Gordon Oliver is the clerk for the meeting and Thomas Radbourne is our Zoom host. Please note that there will be a planned fire alarm test at 10 a.m, but in the event of an actual fire alarm, you must leave the building immediately via the emergency exits. The assembly point is the Dolphin car park. If the lockdown alarm sounds, we will remain seated and await instructions from officers. We will adjourn the meeting until such time as it's safe to proceed. Do members have any questions about the way we conducted the meeting, please? Yes. Sorry, I have some feedback. I'm trying to investigate what the problem is. This is muted. Yes. Proximity. Okay. Better. Oh, fine. Sorry, I'm sorry about that. Do we have any petitions, please?
Apologies. We've had apologies from Councillor Jeff Brooks, from Professor John Ashton, from Superintendent Helen Kenny and DCI Emily Evans is substituting, from Dr. Janet Lippett, from Sean Murphy and George Lawrence is substituting, and also from Jessica Jundu Evans and Hannah Elder is substituting.
Thank you. Item 7, membership of the Health and Wellbeing Board is on an organisational basis.
You're a page out.
All right. Do we have any apologies, please?
We've just done the apologies, so it's minutes, Chairman.
Are there any issues with the minutes, please, that members would like to raise? Could I therefore have a proposal to accept the minutes? Councillor Heather Codling. And a seconder, please. Sarah Webster. Thank you very much. Sorry. Are those in favour of approving the minutes, please? Yeah. Anybody against? Thank you. That's carried. Thank you. And to item 3, actions arising. Are members happy to approve? Sorry. Are there any further updates or questions in relation to any of the actions, please? Joe Stewart.
Thank you, Chairman. It was a question on item number 254. I think, which is talking about the cost of living crisis and looking for contacts in particular in Tilehurst. And I think what's being referred to is what's known as the Tilehurst Poor Lands Charity. If anybody is still looking for a contact, I can give them that contact.
Thank you. The contact on the website was just a postal address.
I know.
We do have a representative of the Thiel Parish Council, but he's stepping down, so perhaps he's not the most appropriate contact. So if you could provide that, that'd be great.
I will do, yeah.
Are there any other issues on the actions, please? So can we move on to item 4? And are there any declarations of interest, please? I take that there's none. Okay, thank you. We'll move on then to item 5, please. Public questions. I'd like to thank Paula Saunderson, who has submitted all of the questions for today's Health and Wellbeing Board. Paula, your question will appear on the screen and will be answered by the relevant board member. You'll then be given the opportunity to ask a supplementary question, but this must just be to clarify the answer given and to the primary question. The time limit is for public questions is restricted to 30 minutes. If all your questions have not been answered in that time, you receive a written response within 5 clear working days of the meeting. Responses given either verbally at the meeting or in writing will be published on the council's website in due course. So it's Paula is there, right? Okay. Could I ask Sarah Webster to answer question A, please?
Thank you, Chair. And thank you very much for the question. Thank you for taking the time to read and provide feedback on our draft primary care strategy. Your comments regarding support for residents with dementia needs in particular are noted, and all feedback will be reviewed by the Bob Integrated Care Board primary care team as part of the next phase of developing and finalising this important strategy. So this will be taken into account. Thank you very much.
Do you have a supplementary, Paula?
Paula, I think you're on mute.
Sorry, there's a delay in the system. That didn't actually answer the question about the admiral nurses, which many PCNs throughout the country have attached to them or part of them. And I was told at the last meeting that you would look at it, but currently there were no plans to have them within our new PCN structure. So how is that progressing, please?
Sarah?
Hi, Paula. I'll take that away for specific consideration, and we will feed that into the next draft of the primary care strategy to make sure that we've considered all feedback received from public where areas perhaps aren't as specific needs haven't come across in the current draft. Thank you.
That would be useful because I think it would be helpful for the GPs.
Yeah. Thank you, Paula. Could we move on then to question B, please, to be answered by Paul Coe, who's the Executive Director for Adult Social Care, West Berkshire Council.
Thank you, Chair. Morning, Paula. Nice to see you. Thank you for your question. Hiya. So, look, I'm afraid I'm going to start with some frustrating news, Paula. The big dementia conversation events have unfortunately had to be postponed. So I'll talk in a bit more detail. But it's been about take-up was quite low, and we want to make sure we do it at a time when people are available to make the best take the best benefit from it. So if I just describe what the events include. So it's been developed to support staff working across a range of posts in adult social care with information about the local impact of dementia and to build on their understanding about dementia across the life course, including preventing well, diagnosing well, living well, supporting well and dying well in West Berkshire. it's been there's a big, really key part of this is including the lived experience stories from local people living with dementia and their carers. The session therefore seeks to bring a greater awareness of what it's like to live with dementia or care for someone with dementia in our district. In addition, the session provides an opportunity for staff to hear from and meet organisations, including, when it happens, the BHFT Memory Clinic, the Alzheimer's Society, Younger People with Dementia, Age UK Berkshire, and Dementia Friendly West Berkshire. This will enable colleagues to broaden their knowledge of the services and activities available nationally and locally. It's not intended, on your particular point about NVQ, it's not intended to be an alternative to or replacement for NVQ or anything. It's a complementary resource to help people with their continuous professional development, and also a chance to kind of encourage reflective practice. I think a key theme that I've picked up is that it will give people who are working with people with dementia a chance to look back and think, did I do the right thing for this person at this time? Do you have a supplementary?
So it will be part of their personal development plans. I think it would be good to try and link it to NVQ's training for dementia, because my experience is that there's not enough people that are taking the NVQs and going on a career path in this direction. So if there could be some kind of just like link within the training to mention the more formal qualifications, I think that would be helpful.
Thanks, Paul. I'll take that away.
Thank you.
Thank you. Could we move on to question C, also to be answered by Paul Coe, please?
Thanks again, Paula. As I say, we've got this delay in delivering the events. I'll add the sessions will look at how statutory services work together as part of the local dementia pathway. The time available will not support detailed review of specific aspects of service provision. So it's essentially understanding what's there and how to best use it, rather than really changing what's available. Where feedback or questions are received from staff, these will be followed up with the relevant service for their acknowledgement and response. So there's a chance to learn and take away for contributing organisations. I think I'd like to say, and it relates to your next question as well, we continue to work as a system on continuing healthcare. More work to be done, of course, but I'm pleased to say there is recently been advised that there is some upcoming training on CHC which will help the local system. Do you have a supplementary?
Yeah, I think I'm hoping that your training is going to be modular. So there will be sessions on some of the interacting services like the bladder and bowel service, where I was told, oh, the family have to pay, when my mother clearly qualified. And with continuing healthcare, it's now over 3 years since I raised this originally with the Health and Wellbeing Board, and a review was agreed, and I still don't think we've got an outcome from that review. So again, my mother was declined continuing healthcare, and she's now on end of life. So I'm hoping that we will get assistance with looking at fast track.
Thank you, Paula. Yeah, I suppose on your modular point, yeah, all of the people working in this sector do need to have a range of opportunities to develop their skills across everything that they're going to come across, really. And I take your point.
Yeah, if you can have little modules, because I don't think a lot of people realise that even if the house is gone, the person under care has all of their, single, they have all their pensions taken apart from £28.25 a week, which is not a lot of money to provide them with their personal needs. And that's one of my biggest challenges, is actually the budget for my mum.
I think we're getting a little bit off the subject matter of the original question, Paula.
Yeah, you're right. Sorry.
Could we move on to question D, also to be answered by Paul Coe, please?
Thank you, Chair. All I'll say...
I think we've covered that.
Okay. Paula, you know my contact information. If you'd like me to pick up other stuff, do just drop me a line. We'll do what we can.
I will do. Thank you very much, Paul. Thank you for your answers.
Thank you, Paula, for asking the questions, and thank you very much for the officers for the answers. Could we move on to item 6, please? Petitions. Have we received any petitions, please?
We haven't received any petitions, Chairman.
Thank you. Item 7, membership of the Health and Wellbeing Board. The membership is on an organisational basis, but we have a standing item to note any changes in personnel. So there have been some changes. Councillor Jeff Brooks has replaced Councillor Lee Dillon, while the latter is on a sabbatical from his role as a leader of the council. Andy Penrith is replacing Helen Kenny as the Thames Valley Police Representative from the 26th of February. Gary Polson will be retiring on the 28th of March, at which point Rachel Peters will become the voluntary sector representative. And could I take this opportunity to thank Gary for all the work he's done over the years, if not decades, in the voluntary sector, which has been very valuable. So I'd like to express not only my personal wishes and congratulations, but also those of the board. Thank you. Can we move on then to item 8, which is the ICB primary care strategy? Could I ask Sarah Webster to give the update, please?
Thank you, Chair. So I'll just quickly introduce my colleague Sanjay Desai, who's joining us on Zoom. He's going to talk us through, give a quick summary. We all had the slides in advance, those who are not going to do a page turner, and then allow some time for questions on this primary care strategy. So Sanjay, thank you.
Brilliant. Thank you very much, and thank you for letting me come in and go through our strategy. So as Sarah said, I'm Sanjay Desai. I'm the head of primary care operations for Bob ICB. I'm not going to do a slide deck. I'm just going to talk because you've got everything there. So why we need a strategy? We know that there are huge workload issues. We know there's more complex patients in primary care, and this strategy is going to hopefully help to address some of those issues that we do have within the patch. We know for certain metrics that we're doing quite well around primary care. So we're trying to build on that, but also then look at those issues that we are having problems with. So the feedback we do get regularly, and I'm sure everyone will know, in terms of getting access to GP practices, the patients are reporting it is more difficult. Same with dental. We know that GPs are having to spend more time doing more administrative tasks, which doesn't seem quite right. We want them to be working at the top of their license and seeing the more complex patients. We're seeing the same workforce pressures both within dental and pharmacy as well. We've seen pharmacies close over the last few years, and also pharmacies not able to get pharmacists to man the pharmacies to be able to see patients as well. So there's a huge demand out there. The demand and capacity is really difficult, and we are struggling with that. So the aim behind the strategy is making sure that everyone who needs support in primary care can see the right person. I think what we want to make sure is that the patients see the right person the first time. What we don't want to do is make sure that the patient goes from person to person. So where possible, for instance, if there's a more self-limiting condition or a less complex issue, we would like the patient to be going seen by their community pharmacist. And I can see my colleague David on the call, so I'm sure David can jump in there. But we want to make sure that the right patient is seen by the right person. So as I said, that's probably the key to all of this. Within the GP practice setting, there is now a huge range of different healthcare professionals that are there, and we want to make sure we mobilize on those and make use of those. And Heike's on the call, so again, I'm sure Heike can sort of jump in if need be. I think the key to this is making sure when we're talking about primary care, we are talking about GP practices, pharmacy, optometry, and dental. So we're talking about the full family of primary care, and we want to make sure that we use each of those sectors the most effectively as possible. We do know that when there are access problems from GP practices, we know patients are pitching up at A&E, and that doesn't seem an appropriate use of the place where we want to see patients. We want to make sure they're reserved for the more complex patients. So in terms of the priorities for us as part of the draft strategy, it's to help manage those non-complex same-day care. So it is that sort of low acuity or low complex patients to make sure they are referred to the right person within the system, and they go and see them. So I'll do a quick plug, probably for David's sake, but also for everyone, that there's a new Pharmacy First scheme which got launched at the beginning of this month. There's 7 conditions that patients can go to a pharmacy and also be treated. I should have declared that I'm a pharmacist by background, so I'm doing a slight conflict of interest there, but a quick plug. This is the first time that patients are able to get treatments from pharmacies in the patch, and things like antibiotics. So actually, and this is only anecdotally, or I should say from one practice this week, they've said that since the Pharmacy First campaign has started, they're seeing about 8 to 10 patients being, they can refer 8 to 10 patients a day into the Pharmacy First scheme. So actually that's really positive, so that the right patients are moving across. In terms of integrated neighbourhood teams, that's where we want to deal with the more complex patients and having the wraparound care with all the healthcare professionals and social care to help support those patients. And then the third strand we're looking at is around the cardiovascular disease prevention agenda, and making sure that we try and put some strategies in to try and address some of the prevention, such as obesity and weight loss, etc., which we know if we can address earlier on, we know that will support patients and they won't develop any conditions in the future. I think, Chair, if that's okay, I'm going to pause there only because I want to give time for questions, and you've got all the documents there, if that's okay.
Thank you. And just as a note, this strategy will be one of the key themes of the Health and Wellbeing Board conference on the 19th of April. Do you have any members have any questions or points they'd like to raise, please?
Thank you, Dr.
Dr. Heike. Please.
Thank you very much, Chair, and thank you, Sanjay, for presenting it. So as Sanjay pointed out, local GP, and as you all know, I'm also cardiovascular lead for Bob, so it absolutely delights me to see CVD prevention as one of the top 3 there. And I think this is a huge opportunity when we look at West Berk's strategy and for the years ahead, and aligning with the Bob strategy, because cardiovascular disease sits there too. So when we talk about the whole prevention agenda, this is our starting point. It is the biggest killer of people in England, cardiovascular disease. And surely if we join forces with what our local authorities can do, what our public health team does, and West Berkshire it's got a wonderful project that has started now in January. That's the Community Wellness Project. I would love for us to throw everything behind that project, because it encompasses the heart of what we're doing, trying to do with prevention. So Sanjay, I welcome and I thank you as Sarah for this strategy. Thanks.
Yeah. And just to sort of on the back of that, just to say that we are focusing on cardiovascular disease first. We're trying to, work out how it all works, and then we'll move to other conditions. So that's not to say we're not working on the other ones. This is just our primary focus at this stage.
David Dean, please.
Yes, thank you, Chair. And it's great to hear Sanjay's summary of the strategy, and really great to hear from Heike, who many community pharmacies are working very closely with the whole long-term conditions and CVD program, which we have in place in Bob. I just want to say you mustn't underestimate, the collaboration that's taking place between primary care providers and the ICB, especially, and I can speak for community pharmacy. The new introduction of the Pharmacy First service is the biggest thing that's happened in community pharmacy for over 10 years. It's the first time in 10 years that pharmacy have had an injection of real funding and reimbursement to help pharmacies survive the current financial crisis. And even though we're only 2.5, 3 weeks into the service, the anecdotal feedback we're getting from both patients, practices and pharmacies has been absolutely wonderful. The fact that we've got patients waiting for a pharmacy to open at 8:30 in the morning to get treatment for UTI, whereas before they'd have to battle through the appointment system to get a GP appointment, is amazing for both ourselves and patients. With Julie Dandridge's help, we presented to over 200 practice managers and GPs yesterday. and the reception we got, there's always going to be those that doubt the service, but actually it was 99% positive, and really great to hear the amount of work we can do together to help, give patients the healthcare they deserve in Bob, and particularly in West Berkshire. So some really good stuff happening on, down the line for the coming months.
Thank you. Are there any other members? Janine.
Hi there. It's just really to have an understanding of the NHS app. And is this something that is triaged between the GPs, the pharmacies and the patient? So all the information is captured. So anything that happens at the pharmacy is going to be shared with the doctor.
Shall I answer that one, Sanjay?
Yeah, yes, please, David. You'll know.
So one of the great things about the Pharmacy First service is actually some of the money that the government has given to pharmacy, about £20 million, in fact, has been invested in the digital pathways back to GP practice. So every patient that has a consultation with a pharmacist will transmit, inverted commas, a document back to the GP practice, which gets ingested into the patient record, especially when there's any treatment for antibiotics or whatever. So everything is meticulously recorded, which obviously ends up then being visible by the patient in the NHS app.
Thank you. And just to add to that, is that information then accessed by all the hospitals that come under Bob?
It forms part of the patient record. So if hospitals can access patient record now, yes, they'll see that.
Thank you.
Are there any other members wishing to make any questions? Or Sarah?
Thank you. This isn't a question, Sanjay. Don't worry, I'm not going to put you on the spot. But thank you for your presentation. I think just to kind of bring this down to what it might mean for people, for our residents, we know at the moment that generally the feedback is once people get into our services and they apologies for those. There was a fire, a kind of a fire test alarm in the room. I should have chosen better when to start my comment. But we get good feedback around when people are able to access our services, and the feedback is generally that sometimes it is a challenge to get there, to get to the right person. So this strategy, really at the heart of it, is to make sure that people can see the right person at the right time with the right need to be addressed. So we know some residents would benefit from longer consultations with the same clinician each time because they have more complex needs that require continuity of care. And at the moment, sometimes we struggle to be able to offer that. We know that our clinicians in general practice and all arms of primary care want to be able to do more proactive and preventative work. And we are seeing a lot of that across our practices, but hopefully this strategy will help take us further. And we know one of the things that's stopping that at the moment is the level of kind of urgent on the day demand, of which a proportion of that could potentially be seen differently, where you don't necessarily need continuity of care. You just need to see somebody to be able to treat you if you're slightly lower risk. So there's a lot in the strategy. It kind of comes down to the heart of that, and also trying to stop some of the things that we encourage at the moment. And Pharmacy First is a brilliant step forward in that, where you might try and do the right thing and go to your pharmacist, explain all of your symptoms, and then previously to be told, yeah, okay, but now you've got to go to your GP so that you can have something prescribed. That's really frustrating for residents who are trying to see the right service, but then have to have a double step in their pathway. So Pharmacy First is brilliant. The strategy hopefully builds on that further, and it will really link in with our kind of community services, social services and voluntary sector services as well, because if we're really able to develop further on the preventative, proactive care arm, and the strategy talks about sort of integrated neighbourhood teams, that's all about bringing all of the professionals together to be able to offer what will hopefully feel like a seamless service to our residents receiving it, as opposed to different public services at the moment. And I appreciate that I may be talking about a utopia, and we're seeing how close to that we can get within the realms of reality and what's realistic. But that's what the strategy is seeking to kind of get us to a place that we're not at the moment. So I'd really encourage you all to speak to your constituents about this, talk to people about it when you're out and about. Primary care really is one of the most talked about areas of healthcare, where we get an awful lot of questions and interest. So please do encourage anyone you speak to, particularly if you're residents here in the West Berkshire patch, to provide the feedback. And there's the link in the pack to be able to go into the engagement portal and provide feedback. Thank you.
Thank you. Are there any other questions or points? There's a couple of things I'd like to raise, actually. First of all, on Pharmacy First, the day it was introduced, I did a Google search to find out which of our local pharmacies were taking part. Didn't find anything. And I think there's an A4 size poster in my GP surgery and a similar size one in the pharmacy, my local pharmacy window. But I think perhaps we could do a little bit more to publicise the programme and the conditions which it covers. The other thing is, I noticed in the strategy that there's a talk of kind of moving funding really from acute care to primary care, and I can understand the reason for that. But what I'm worried about is it's the old story. If we want to get there, we wouldn't have started from here, kind of thing. With our local hospital with a budget of 10 million deficit, are we going to be robbing Peter to pay Paul, basically?
So I can answer the latter question. Then I think that the first was more of a point for us to reflect on in terms of the comms around Pharmacy First. So in terms of the move around where our NHS resources go, we're working through our financial planning for next year at the moment, and we absolutely want to be able to invest in preventative and proactive services where possible, and as much in our communities as possible. You've rightly acknowledged a risk to destabilising services as they are at the moment, and the fact that, as you've stated, Royal Berkshire currently have a deficit financial position, and are working really hard on that as well. So it's not a simple shift of resources, and what it comes down to is, first of all, looking at how can we better align our resources that were potentially there's duplication or waste at the moment that might then free up some resources to invest elsewhere. Looking at our model of care and where can we shift to a more preventative model, which will then mean over time resources can move out of the kind of the balance of where time and resources sit will hopefully be less in the acute in terms of that. If we're able to change the trends and direction of travel on increasing comorbidities and complexity of needs, if we can get to them sooner and help people stay well for longer. So that's absolutely the ambition. I can't give you a very clear answer right now on how exactly we're doing that, because we're still working through the detail of how to move resources around an incredibly complex system without destabilising in the meantime.
Thank you. Are there any other points? Yeah, thank you very much, Sarah. And so I've got no colleague's name.
I can take the question around the advertising for Pharmacy First. The national advertising started on Monday. So the NHS has produced a 30-second TV advert, which has started to go out through social media, and I think is going on TV in the short future. The Bob Comms team have started to initiate their strategy and their plan. So you will see lots and lots about Pharmacy First over the coming weeks. It was actually designed on purpose not to be a big, massive launch on the 31st of Jan, because this is so new. We've had to facilitate the training of over 350 pharmacists to enable them to be ready for being confident around clinical examination. So it was done slightly on purpose not to give it a big bang approach, but you'll see the communications and lots of things happening over the coming weeks and months.
Thank you. So basically, it was a soft launch.
Correct. Yeah.
Thank you very much. Probably very sensible in the circumstances. Thank you. Sanjay?
Yeah, I was just going to come in also just on the resources issue, Chair, that you spoke about. Within the strategy, we've talked about resources, but some of that is not just financial as well. It may be, for instance, we might be looking at where can staff move around actually to make sure we try and fit where we need them to. So do we, for example, move secondary care staff out to primary care to work? And I suppose the last plug, actually, Chair, if it's okay to say that we're consulting or engaging, sorry, I should say, until the end of the month. But we've done quite wide focus groups with various different patient groups. But if there are any that you want support with, we would be happy to support you with coming out to talk about the strategy.
Thank you. Can we move on then to item 9, the resilience of community pharmacies? And could Julie Dandridge present the report, please? Julie Dandridge doesn't appear to be available just at the moment. Shall we move on then to item 10, and then we'll come back to item 9 later. Could I ask April Peppedy to present her report, please?
Thank you, Chair. So hopefully you've all had an opportunity to read the paper. So the report provides details of recent and planned changes to pharmaceutical services in West Berkshire and advises the Health and Wellbeing Board on the implications for the pharmaceutical needs assessment. There are 4 elements covered by this report. 1, unforeseen benefits application for a new pharmacy in the Kingsland Centre, Thatcham. Comments made by third parties on the unforeseen benefits application for a new pharmacy in Newbury Town Centre. Changes to opening hours of the Boots Pharmacy in Northbrook Street, Newbury from December 23. An application with respect to distance selling premises in Hambridge Road, Newbury. The first 2 elements were considered by the Pharmaceutical Needs Assessment Subcommittee on the 23rd of January 2024. Responses were submitted to the PCSE on the 24th of January, supporting the application at Thatcham. A separate letter was sent to PCSE on the 24th of January, highlighting issues with comments made by Day Lewis Pharmacy in relation to the Newbury Town Centre application. Changes to the Boots opening hours are very minor, opening 30 minutes earlier, Monday to Friday. So there are no implications for the pharmaceutical needs assessment. Notification of the application for distance selling premises was received after the Pharmaceutical Needs Assessment Subcommittee had met. So the board is, given that distance selling premises are required to serve patients anywhere in England, it is not considered that this would have a material impact on existing pharmacies in West Berkshire. It is recommended that the chairman be authorised to respond to the consultation on behalf of the Health and Wellbeing Board to confirm that there are no implications for the pharmaceutical needs assessment and that the board has no objections. Hopefully that provides a summary, but happy to take any questions there may be.
Thank you.
Chair.
Do any members have any questions or issues that wish to raise, please? Sorry. Oh. Sorry, Joe.
The reason I hesitated is because I'm not exactly sure how to form my question. So I apologise in advance if this becomes, I will try not to make it too waffly. I'm bearing in mind quite a lot of our agenda today is about pharmacies, and the conversation that we've just had in particular about pharmacies and how they are going to become even more vital in our primary healthcare services. And from my experience, I'm a Tilehurst ward member, and I know that the Tilehurst pharmacy in particular has really struggled for many years in terms of delivering the service, in particular through COVID, but still that continues. And seeing in this paper, and this is going to be very much about my lack of knowledge and experience in these matters, but seeing people saying that we should refuse a new pharmacy for various different reasons seems quite strange. And I wonder whether anybody on the call, in particular our experts in the pharmacy world, might be able to explain to me why we would think that we would turn down any application, particularly as it's an unforeseen benefit. And surely we're going to need to rely on more and more pharmacies if actually that's where we're going to be putting a lot of our services, our initial service need. So like I say, that was a little bit waffly. It's sort of, I'm forming it as I'm thinking about it. So if anybody can answer that question, I would love to hear responses, if that's okay, through you, Chairman.
That's fine. I mean, your points are well made, I think. I should have invited David Dean actually in first, but perhaps it's an opportune moment for him to come in now.
Yes, thank you for that. I'm unable to comment on individual applications because there's an appropriate legal process to follow, but just wanted to illustrate the problem we have with the way that community pharmacy is funded today. It's a fixed sum of money that's been the same pot of money for 10 years now. So when you look at how many pharmacies have disappeared from Bob, so 20 in the last year and a half, it's because the pot of money has remained the same, but the volume of prescribing and dispensing has gone up a lot, and the level of costs for salaries, rents, energy, all the other bits and bobs have gone up as well. In fact, I think in real terms, about 40%. So if you open new pharmacies, that could affect the financial viability of pharmacies that are already there. So it could push them below their financial criteria to remain viable. So I do sympathise with access to pharmacy, and the ones that are around at the moment are doing their level best to be viable and work with the local community and provide all the pharmaceutical services they can. But if we start opening brand new pharmacies, it could mean that the ones that are there now could end up closing.
Thank you. That's really helpful.
David Marsh.
Thank you, Chair. And apologies for being late earlier, and if I've missed some of the earlier debate that touched on these matters. I just wanted to say that in terms of Newbury, the Town Council strongly feels, which I'm a member of, the Town Council does feel there's a need for another pharmacy in the town. It was pointed out, I mean, it was if the paper is to be, if the local newspaper is to believe, Boots were trying to block plans for a new one. It appeared, I take the point that's just been made about the pot. There's not much we can do about the size of that, but it's a bit dispiriting if they were trying to, for commercial reasons, trying to stop what is perceived as being a local need. And as was pointed out by the applicant, we've lost 2 pharmacies in relatively recently, Lloyd's and Superdrug. So we do feel that there's a need, and that we have been supporting this particular application for that reason. There's as a consumer, as it were, one is used to very long queues. I was surprised actually, because I'm normally quite healthy, and I had to go to the Boots at the retail park in Newbury, and my wife said, well, you better allow half an hour to queue up. And this wasn't at necessarily the busiest time of the day. So I think clearly there is a need for more, and I hope we can get them without threatening the existing ones, as you've just alerted us to. Thank you, Chair.
Thank you. I think most of us here will know of queues in pharmacies. My pharmacy seems to vary fantastically from no queue at all to being kind of 30 or 40 minutes, which is a bit odd. Gary Pelson.
Yes, thank you, Chairman. Yeah, I find myself in agreement with David and Joe actually on this issue. That it's plain to see that there is a demand, and the queues are really quite long. I've experienced them myself in our local pharmacies, and I do question whether or not some of the objections to this are such like crocodile tears. Really, I mean, there's a profound commercial interest in wanting to obviously discourage other businesses to come in, but I would imagine that the applicant will be aware of this pot of money and that they may well be due a share of it, but equally they might understand that amount of money may not be as much as they'd like. But I would imagine they'll have worked out that they can make some money, and that's going to be good for customers.
Thank you. Are there any other questions or points, please? Sorry, David, is that an old hand or a new one?
It's an old hand. Apologies.
No problem. We have quite a long recommendation, which are A, to note the changes to pharmaceutical services in West Berkshire, B, to note the decisions made by the Pharmaceutical Needs Assessment Subcommittee on the 23rd of January 2024, and C, in relation to the application for inclusion in the pharmaceutical list, a ground floor flat 1, 4 Hambridge Road, RG 145 SS, in respect of distance selling premises by Halo Pharmacy Limited, to agree that the chairman of the Health and Wellbeing Board should be authorised to respond to the consultation to indicate there are no implications for the West Berkshire pharmaceutical needs assessment, and that the board has no objection to the application. I'd just like to point, I did do a quick check. That premises is not, although it's called a flat, it is currently in commercial use. Could I have a proposal, please? Sarah, thank you. And a seconder, please. Paul, could all those in favour please show? So, is there anybody against? Thank you very much. That's passed. Item 11, right care, right person update. Could I invite, sorry.
I think we've got Julie now, so we can go back to the.
Oh, sorry. We've got, we can go back to item 9, sorry. Let's go back to item 9, the resilience of community pharmacies. Could I invite Julie Danbridge to present her report, please?
Thank you, Chair. And it seems that you have a bit of a pharmacy focus on today's agenda. First of all, can I say I seem to be moonlighting as Sarah Webster. I am, in fact, Julie Dandridge. I am the head of pharmacy, optometry and dentistry at the Integrated Care Board, and I'm joined by my colleague David Dean in LPC, who I'm sure you are all aware of. And thank you for that. And it's very good to be able to present this paper, and I hear of the queuing in pharmacies that I have that I've come into the back of. So I present my report as an update on the provision of community pharmacy across Bob, but specifically across West Berkshire here today. I think we all recognise the valuable contribution that community pharmacies do pay to the population, and a really critical part of the primary care infrastructure alongside general practice, optometry and dentistry. And I present some really high level figures in terms of what community pharmacy does in terms of items and various bits and pieces that are dispensed. And in Berkshire West alone, you know, the numbers are quite significant. I think it's something like 130,000 items a month. If we just look at, so there's a couple of things that I wanted to cover off. Pharmacies who have given notice and a closing, a little bit about how community pharmacies have changed their hours, and also a little bit about how we are seeing community pharmacies change as we go on and go forward. Delighted to say that the Pharmacy First scheme of pharmacists offering additional services and being able to treat 7 common conditions has launched really well across Bob and West Berkshire, and we've got some really good working between general practice and the pharmacies in terms of working out how patients can be referred from one to the other. In fact, we had 200 people on a GP webinar yesterday listening to how the service can set out. We've also got nearly all pharmacies across Bob signed up, all pharmacists in Western Berkshire signed up. So the numbers providing the service are really good. I think when I was first asked to write a report and bring it to the board, we had seen a number of pharmacy closures across the patch. We had all the Lloyds in the Sainsbury's closing, and we had one or two of the other big chains closing branch, which I know had a particular impact in the West of Berkshire. So I think we went through quite a rough time. Now, as I just came into the back of, we are getting more and more applications for opening of new pharmacies, but we're also seeing a little bit of a shift in terms of new independent pharmacies or smaller chains coming in rather than the bigger chains. And I think this is really important for the high street and the community, where you've got a lot more sort of local provision and local delivery, and those small independent pharmacies are more likely to become part of the community, part of linking in with the GP practices and other primary care services. So I think there are some going forward. We don't take any notice of closure lightly. We really look at the impact on the surrounding practices, how many prescriptions are being dispensed, whether the local pharmacies are able to deliver those numbers. And actually what we're seeing in some cases is it's strengthening those existing pharmacies to become more viable than not. And in all cases, I think we've found that's helping. Now, I do take on point that the view of having to queue to collect prescriptions and things like that, and I think that's something that we do need to feed back for our community pharmacies. Some of you will be aware that you can now order you have been for a long time, be able to order your repeat prescription on the NHS app. But what you can also do now this year is you can track where it is in the system, whether it's still with the GP or whether it is at the pharmacy. So I think there are some good things that may help that out. At one stage, we went through pharmacies having to close for various reasons, couldn't get locums, etc. And people would turn up to collect their medication and the pharmacy will be closed. New regulations brought in whereby pharmacies now have a duty to inform the commissioner, but also have a continuity plan in terms of how they deal with that. And thankfully, those numbers have rapidly drop down. However, we do know it's not all rosy. We do know there is an issue with pharmacy workforce, making sure that there are pharmacists in place, and our independents tend to have more permanent pharmacists than some of our bigger chains. So we do need to try and work with the School of Pharmacy to try and give more opportunities to our local graduates, and to support those that are new to practice in a similar way that we support our GPs that are new to practice. So we are trying to develop a work programme where community pharmacists want to come to work in Bob and provide services to our local community. And we really do need to capitalise on having a local school of pharmacy. You will have heard about the draft Bob primary care strategy, and I think that will really help embed community pharmacy as that an important pillar in primary care. Chair, I'll probably stop there, but very happy to take any questions, and I know my colleague David will too.
Thank you. The next item I've got here is to invite David Dean to comment on the perspective of the local pharmaceutical committee.
Yes, thank you, Chair. Yeah, I just want to say that we've been working very closely with some of the new owners of the ex-Lloyds pharmacies that disappeared from our high street several months ago. And I've been particularly impressed by their enthusiasm and willingness to work with local communities. And I know that Dr. Feltman, who's on the board, has had several meetings with the local pharmacists to work out how they can embed themselves even more within the local community. And Julie's right. When you get an independent pharmacist taking on what was a dying business when Lloyds sold up, you see a breath of fresh air come through the community, and they're far more flexible and helpful. So things like they will offer free deliveries, which is outside of the NHS contract, but they're more than willing to do that to try to help the local community understand all the other things that they can offer. And for things like Pharmacy First and blood pressure checking and oral contraception, all these new pharmacies that are taking on the ex-Lloyds are signing up to everything and delivering everything. And they're investing in their workforce. They're running 2 or 3 pharmacists a day in some of the new businesses. So that's their capacity plan, if you like. Some of them are held back by the size of the premises, and some of them are investigating whether they can extend or build new consulting rooms, or even introduce self-service vending machines outside their pharmacy to help those professionals that can't get to the pharmacy during working hours, but can collect their script outside of those hours. So lots of things happening behind the scenes to help with the sort of resilience of the pharmacies that are left to deliver. Sorry, Dr. Feltman, I know you had your hand up.
Thank you. Dr. Feltman.
Thank you, Julie and David. And I'm sure all of you know, as a local doctor, this does speak to me, the resilience of our community pharmacies. I'd probably like to make 2 points, which I've made in a previous meeting as well. When we look at our community pharmacies, it is not just the distance to travel, and for me, that is where the needs, the needs assessment that we all refer to strongly focuses on. The delivery of what our community pharmacy can now do is far greater than what it was when that was initially set up to. So I would drive for us as an ICB to think of community pharmacy in the new context. What can our new community pharmacy do? And in that same breath, looking at our population that is expanding, wherever you drive along an A road, there are new housing estates opening. So we need to think of resilience and sustainability when we say new pharmacy, what our pharmacies can do, or rethink when we say, no, we don't need an extra one, or it's okay for one to close. So that resilience and sustainability, looking at our expanding population in Bob. I love what David said, the opportunity that comes with new independent pharmacies. It's a new way of thinking. It's can do rather than the potential group think of bigger corporate organizations. And it's a huge opportunity for that neighborhood working that is talked about in our primary care strategy to help capitalize on that. So sort of a word of caution, and then also the opportunity that comes with us. Thank you.
Thank you. Heather?
Thank you. Can you advise where the community pharmacies sit with those pharmacies that are attached to doctors' surgeries? I have one particular one in my ward that I probably get an email or a phone call about weekly about the wait that people have of potentially over an hour, They're not allowed to do repeat prescriptions unless they take the script in. They are starting to do them via the app, but not everybody within this rural ward has the knowledge or even the ability or even the inclination to order it via the app. And it's becoming quite a frustration. So I'm just wondering what we can do to move this surgery on. They won't allow, the doctors won't allow them to take their prescription elsewhere. It has to be filled at that pharmacy. And that is becoming a real problem because they're only open, I think it's 8:30 till 6. If you're working away from the village, which a large number of people do, and that area, it's a real problem for them.
There's a legal issue here. The direction of patients to one pharmacy is actually illegal. Patients have the choice to go wherever they like for their prescription. And if there is waits of an hour, it may be that local processes aren't in place, such as setting up, you say using the app to order prescriptions. The patient doesn't need to do all the work. The surgery should be planning ahead for a stable prescription. They can put into the system sort of 9-10 months worth of scripts, and they'll just pop up as soon as the last one is claimed for by the patient. The next one gets sent to the pharmacy for preparation and ordering. So all that should be happening behind the scenes. There should be no need for queues of that length in the pharmacy, but only if every single patient is being treated as what we call a walk-in, where they're just given a script, a paper script usually, and just walk into the pharmacy to collect. And that means the pharmacy can't prepare their prescriptions in advance. They don't know what needs ordering in advance. And that puts a lot of pressure on the pharmacy, unnecessarily so. So it may be that you drop us a line, myself or the ICB separately, and we can have a look at this particular pharmacy and practice and see how we can help them.
Thank you. That would be very helpful.
Yeah, very, very happy to look into individual cases. And it may be that it may be that it's a dispensary associated with a practice that is working in this way. It sounds like you're in a rural a rural part, but whilst there are only defined radius in which patients can be dispensed to, that does not necessarily mean that that patient has to go there. So the GP has a defined list to who they can dispense to, but that patient still has the choice to either go to the practice dispensary or go to another community pharmacy.
Thank you very much.
But we're happy to look into it.
Thank you. April.
Thank you, Chair. It's just a little bit of a reflection in terms of what we've been talking about this morning, the work of Pharmacy First, our pharmacies, and the primary care strategy, and the community, the CVD prevention work in terms of the community wellness outreach programme. And I'm just thinking of how we could easily kind of try and join some of these things up in terms of the community outreach programme could be promoting Pharmacy First programme, and similarly our pharmacists could be helping us promote the community cardiovascular disease outreach programme as well. So I think that's something I'll take away as a bit of thought about how we can join that work up.
That's a very good idea. Thank you. Janine.
Thank you. It's just checking my understanding. So Pharmacy First, I love the idea, I love the concept, but I'm concerned about how some of our chemists can accommodate it. So think about Tilehurst. We've got 2 chemists in Tilehurst, and they service a huge area that has been rapidly expanding. It's at capacity. Certainly for myself, I was at the doctor's. They put through a digital script. I went to collect it in the afternoon, so at least 5 hours had been given, and that script wasn't prepared. So these all add to the pressures. So we're becoming a lot more dominant. We're becoming a lot more dependent on digital equipment to get our scripts. How does that impact on people who are digitally not inclusive? I wanted to use the word exclusive, but that's not quite where I was going. And how reliant are we going to be on the NHS app, and what happens when that fails? So I know I'm a bit of a doom and gloom monster here, but I just don't see this all helping us, the community, especially when you've got the chemists are at capacity. And my concern is with one of those chemists in Tilehurst, it does service quite a large old population, elderly population. And quite often when they go in, a lot of time is taken trying to, with the conversations, because they're hard of hearing. So this all adds to it. We're not thinking of some of the human reasons for those scripts, for those chemists with the queues. And then there's the patient's patient aspect, us being patient. So hopefully you've garnered something out of that. How are we going to cope with some of those issues?
So maybe I'll start, David, and then pick. So I think digital inclusivity is really important to us, and clearly recognize that it's not the be all or end all, but it can help and assist, and does make the community pharmacist easier, because they can plan ahead, they can dispense in quieter times because they've had the prescription go down through the spine. Also helps patients in terms of being able to order it. And I know it doesn't fit anybody, and in fact I was hearing of a PPG event in Newbury at one of the practices where they opened up on a Saturday. They had about 50 members of the public. Some of them may be in your areas. And those members of the public came in and they converted a whole load of people into using the app and seeing how easy it was. I totally agree it's not for everybody, but for some it is really difficult, really different. I think there is and I think in terms of workload and things like that, I think we are seeing a shift in the services that community pharmacists offer, and actually the labelling dispensing is becoming more automated, more simple. I'm a trained pharmacist. I started in community pharmacy many times ago. I was still using a triangle to count out my tablets out of a thing. Now everything is pre-packed, and we now have machines to do that. Not available everywhere, but I think the opportunity for Pharmacy First gives community pharmacists a real opportunity in the community. This is really what they did their degree to do, is to help patients, to offer that service. So I think we will probably see a shift to more people wanting to come into community pharmacies to offer those more clinical services rather than the labelling and dispensing, which remains important, remains a critical part of the programme, but doesn't necessarily need a skilled individual or a pharmacist taking the whole time to do it and dispense it. David, did you want to add anything?
No, I mean, not all digital is patient facing. 95% of it is behind the scenes and will enable pharmacies to give them more time to spend with patients face to face. We've got some pharmacists who've initiated some new systems now, and it's given them back 3 hours a day to do nothing else but to talk to patients, which is fantastic.
Thank you. Heike, is
Sorry,
that sorry.
Sorry, I've just got one more question that I thought of on the back of that one, sorry, which is how do you service the rural community when they're probably 10 miles away from a chemist, especially if there isn't public service to get to those chemists? I'm just trying to really think out the box to really make sure that the Pharmacy First agenda is covering all aspects, especially in poor weather when people can't get out. How are we going to be able to look after those people if they can't get to the doctors and they could take part in one of the services provided from Pharmacy First chemists?
Shall I take this one quickly?
Yeah.
We don't do a sort of a home sort of service for this just yet anyway, until the government maybe comes up with it. But every patient can access Pharmacy First remotely, and I know we're going to go down the digital literate route again, but that is an option for many patients. And that also covers, I'd rather, a patient goes to their local community pharmacy, but the online pharmacy route is also open to every patient if they so wish, where they live in very rural areas.
Thank you. Mikey, is that an old hand or a new one?
No, I actually wanted to also comment on Councillor Lewis's point. I think it's really viable, and what Julie said, in an era where we are only going to be using more and more digital, I think this is as much an opportunity. How can we use our local voluntary sectors, our Health Watch, to find out where are those groups? How can we help them? Because otherwise, they will constantly be left behind, and that is an inequality in itself. I love what April said, already thinking of 2 projects that are up and running, our community wellness outreach project, but yet again, so that will be reaching the small areas where they can. It's a starting point. It is in mobilizing active things like that, where we can help the digital inclusivity, in incorporating, because we can't always leave people behind. That is for sure. Even in GP appointments, now accessing this, getting medication, if not for the patient themselves, then their carer, their family member. Judy mentioned at a PPG meeting where they took that opportunity to speak to 50 people, the inner PPG group, to practically there and then look at your NHS app. For me, it would be in things like that where we make it real. It can't just be something on a slide or that we talk about in a meeting. How are we going to make it real for our population? Let's start in Berkshire West, or West Berks more specifically, because this is our specific area. It's my patients, it's yourselves. Thanks.
Thank you. Sarah.
Thank you. I just wanted to be really clear as well that when we're rolling out more digital access routes, we are not taking away the traditional routes as well. So it should help those people who don't want to use digital routes as well. So if you use the GP appointment example, previously we'd have had 20 people calling up at 8 a.m. and sitting in a long phone queue. If 15 of those are now using the digital route, that means the remaining 5 will get a quicker response to their phone call. And it would be the same with prescriptions. If 50% of those are being sent digitally in advance, it allows more, it means those who turn up with their script, for example, will be able to get it quicker. So we are not proposing to remove the traditional routes, and digital should benefit everybody, even those who don't choose to use the tools.
Mike.
Thank you, Chair. I just wanted to comment that I'm on the PPG of Strawberry Hill and took part 2 Saturdays ago where, well, I actually did a little more than make the tea and wander about, but where we actually had a talk from one of the GPs who seems to be very into IT compared to some others. And we had about just short of 50 people turn up. And they were all helped to actually get the NHS app on their phones. An interesting thing had cropped up prior to that, which doesn't have an answer, and that is some of the perhaps older generation couples have a common email address. And of course, you have to have an individual email address to use the NHS app. And for whatever reason, members of this couple didn't actually want to change it to their own email address. So in the end, they had to do it. But it was interesting that even then, people are very encouraged by the app and seem keen to use it.
Thank you. The point about email addresses, I think, is very valid. I would imagine there was a very large number of families in that situation. I'm in a similar situation with mobile phone numbers. My mobile phone uses mine. Are there any other points? Okay, well, thank you very much, Julie and David, for that. It was very, very fruitful. Thank you very much.
Thank you.
Can we then move on to item 11? And can I invite Detective Chief Inspector Emily Evans to present the item on right person, right care, right person. Thank you. And sorry for the delay.
That's okay. Morning, everyone. Hopefully you've seen the power presentation that was sent out by Helen in advance of the meeting. So the National Partnership Agreement was published in July last year, and it's around sort of like the inappropriate and unavoidable involvement of the police responding to people with mental health needs, where there's no criminality or any real risk to the life of the person or serious harm. We're not necessarily the right agency to respond to that. So there has just sort of some key points really. The right care, right person has been adopted for concern for safety. So for welfare checks, where somebody calls into the police that they're concerned about one of their family members, they haven't been able to get in touch with them, they're concerned around their mental health, might be able to get out and check them immediately and respond quicker than another agency. Or if they walk out from psychiatric hospitals, we've obviously got Thornford Park. So clients there are, if they do walk out or they don't return, we're contacted to be that sort of like primary resource to get out and support them. And obviously walkouts from healthcare settings as well, where there's that real risk around mental health. The demand does appear to have gone down when you look at it compared to sort of like this time last year, which may be as a result of when calls are made to emergency services, they are getting the right appropriate care, the right person that attends that call rather than just navigating it to the police. What we have to remember is that it's a very young workforce that we have, you know, in West Berkshire, in all of the areas really in Thames Valley. Those officers won't necessarily have the correct training in order to try and manage mental health and manage sort of challenging individuals that really need to be diffused rather than often leading to arrest, which isn't necessarily the right outcome. And that's a multi-agency partnership, which is sort of like formed, which has been happened since our last board. I know that there's quite a lot of discussions in local implementation groups, and some new processes have been implemented by partners. So we are sort of always keen to look for sort of like feedback around that, and understanding the impact around patients as well, and looking at case studies. We provided the Right Care, Right Person strategic leads, I think, and also our mental health lead for TVP. Lots of presentations have gone out to multi-agencies, meetings, a sort of a strategic level in order to try and increase and improve awareness around making sure that we have the right care, right person. And it used to be that we would always support the ambulance service if they were called to somebody that was presenting difficulties. And that still does happen. And I'm really confident that we've got really good working relationships with those other emergency services, and we do the right thing to support each other and provide that service. But very quickly, we need to sort of withdraw, because sometimes the police actually being there can sort of cause people to be more agitated. So those other agencies will have a better calming response. So I think that's probably the best sort of the highlights from those slides.
Thank you. Members have any questions or points they wish to make?
I got off lightly then.
Not yet. There's a couple of points I'd like to make. First of all, a specific point. You gave some contact. There's some contact details in the slides. And there's one for, I think, the control room, but it was a personal email address. So I wondered what happened if that person was on leave or just wasn't on shift at that time.
Okay, I can make sure that you have the right details for the control room. But that will obviously just be on that 101 number, but it was going to be a point of contact for the control room that takes the lead in the right care, right person strand.
And the other one, I think I've got slightly confused, because I was under the impression that you didn't respond to kind of mental people absconding from mental health institutions. And the other thing I was wondering about, if in a situation, we had a situation a couple of months ago where I think there's a lady with dementia kind of walked out of one of our care homes and walked for some distance and was actually, I think, picked up by an ambulance service. But in those kind of cases, I'm not quite sure how the managers of the home or the council would be able to find that lady without the help of the police.
we do get involved in those instances, and we treat them like a missing person investigation. So sometimes when we've had calls around people suffering with dementia, we get out and provide an immediate response, because often they are located in the immediate vicinity as to where they've gone, or there can be some inquiries that we can make as the police to try and locate them as quickly as we can. So hopefully that's provided you a bit of confidence around that.
Thank you, that's reassuring. Thank you. Are there any other issues? Yeah. Well, thank you very much. I think item 12 we've deferred.
Yes.
On to item 13, then the voluntary sector update. Could I invite Gary Paulson to present his report, please? And I think you'd like to ask Rachel, who's your current deputy, to assist.
Indeed, Chairman, thank you very much. Yes, over the last 18 months, since we managed to appoint a partnership and engagement officer in the person of Rachel, we've been finessing the various voluntary sector voice forums to include the Special Educational Needs Voluntary Sector Forum, Children and Young People's Forum. We now have a sport voice, and also an art and culture for wellbeing voice. So those meetings are now taking place regularly, and we're finessing the work that's being done, and we're taking that work forward to respective bodies, whoever it affects, and trying to come up with solutions. And I think what we wanted to do now is really just give you a very brief flavour, really, of the sorts of things that come up. Rachel's got a few words to say. And then really perhaps she can then work with perhaps Gordon, may I suggest, to develop a suitable template that would be meaningful to the Health and Wellbeing Board moving forward.
That would seem very helpful. Thank you.
Okay, thank you. Rachel, do you want to come forward here? Does that one work?
Yeah, thank you. Thank you, Chair. Thank you, Gary. So as you will have seen from the report we provided for the steering group, we currently facilitate several forums that Gary's mentioned, and they are really an opportunity for the sector to share issues and challenges that are affecting them, and bring them to the forums where we can identify common themes and work together to find appropriate solutions. The SEND Providers Forum, Special Educational Needs and Disabilities Providers Voice, is a great example of how we're evolving these forums, as Gary mentioned, to ensure that we've got the listening ear of the public sector service providers and policymakers. So, for example, with the SEND Voice, we have Alicia Stevens, who oversees the West Berkshire Youth Forum. We have Miranda Walcott, dedicated clinical officer for special educational needs and disabilities from Bob ICB. We've got Alex Ostatira from the Advocacy People, who oversees the Learning Disability Partnership. Heather Codling, portfolio holder for Children, Education and Young People. Hannah Cole, chair of the Autism Partnership Board, and various others from West Berkshire Council that join us and provide us with updates and have a chance to listen to the members. This has been really valuable and creates opportunities for collaboration and partnership, working on drawing the expertise of the voluntary sector partners to help shape services, and also to provide first-hand experience from their service users. On Monday this week, we hosted a voluntary sector voice, which is an overarching voluntary sector forum from anybody that's working in the voluntary and charity sector across West Berkshire. And Sarah joined us as our guest speaker. I just wanted to run through some of the key issues that came out from the members, and they were representing 25 voluntary sector organisations that joined us. Firstly, the impact that poverty is having on creating more complex cases and higher referrals. For example, food banks are not simply providing food anymore, but also providing wraparound support, including cooking equipment, where households might be in temporary accommodation and only have a kettle as their means of cooking. The complexity of cases and increasing demand is causing issues with recruiting and retaining both staff and volunteers, particularly in getting the specialist skills needed to support service users. And in the case of volunteers, some roles are no longer as enjoyable for them as they might have been. So they're either not taking them up or they're not staying very long. This is a challenge across the country, and it's important for us to continue to invest in volunteer recruitment. Less capacity in public sector services means that more is being shifted to the voluntary sector, and without the adequate staff and resources, they are having to adjust their services to reflect their own capacity. Where recruitment is successful and demand on services increases, this puts additional pressure on the charities to grow, and ultimately they need bigger or more premises and spaces to work from, as well as core cost funding. Short-term funding and commissioning is particularly difficult for charities to enable them to be strong and resilient. There's also less funding to go around as grant givers are seeing the cost of living impact on their donations pot. So even when applicants are good, they're not getting funds, or they're only getting a proportion of what they applied for. However, the expectations on their delivery outcomes don't shift to reflect this reduction in the grant that they're receiving. In short, we look forward to formalising the way by which we communicate these challenges and issues to the Health and Wellbeing Board, so that there will be a transparent and robust process by which we share information and work in collaboration to find solutions. Thank you.
Thank you. Thank you. Do any members have any questions or any points they'd like to raise?
Can I just say, Mr. Chairman, thank you very much for your kind comments earlier on. I think it's what I've seen over the past 25 years, really. It always used to be, the voluntary sector used to be regarded as the added value to statutory services. And whilst that's still true, the voluntary sector is now becoming the value, actually, and becoming the institutions and the solid institutions that people rely on. There has been a real shift in this past 15 years or so. And I think it's very important to really embed the work of the voluntary sector within this forum in particular.
Thank you. And once again, thank you very much for your service, and welcome to a good retirement and happy retirement. And I believe that Rachel will be coming to the board in the future to represent the voluntary sector. Thank you very much. Could I move on then, please, to item 14, young people and vaping. And I understand that George Lawrence will be available to answer questions on the report.
Alan, could I just say something just before we move on? Is that all right? Sorry, I put my hand up, but I think you missed me.
Sorry, sure.
So I think it was really interesting to see all the different groups and things that you're involved in. And I know I've been invited to come along to the Sports Voice meeting. So I'm just wondering, a lot of this work and things that you're talking about fits into some of our steering groups that we have that sit underneath the Health and Wellbeing Board, and it's just about how we might be able to capture some of that learning and bring that into some of the groups. So Rachel and Gary, if you're still here, before you go, really happy to perhaps have a catch up with you to think about that in a little bit more detail of to make sure that we're lining up.
Thank you. It's a very good idea. Thank you. So move on to item 14, young people and vaping, and George Lawrence is available to us to answer any questions on the report. I hope everybody's read the report, and I hope there's some questions and issues, please.
Yeah, thank you, Chair. I'll just be very brief, and I hope everyone has had the opportunity to read this. So while nicotine is substantially less harmful than smoking, most e-cigarettes do contain nicotine, which is highly addictive, and this can cause harm in adolescent brain development, and there may also be other harmful substances. The data that we've collected and local data, national data, shows that the proportion of children experimenting with vaping has grown, even though this is illegal to sell these products to under 18s. Everyone will be familiar with the marketing of vaping. This includes easy access to vapes, appealing flavours, bright and inviting displays, and the risk of nicotine addiction are the recognised factors driving the increased use of vapes by young people. And we have actually seen products like sippy cups being used as single-use vapes. We know from many years of delivering young people's harm reduction strategies that a holistic approach is needed. And working with the retailers and the wider enforcement initiatives, these need to be delivered alongside targeted public health education interventions that will allow for those informed decisions to be made. Trading standards is at the heart of all of this and is illustrated by our awareness programs in the paper with our schools interaction, as well as the operations that we conduct, such as Operation Tannock, Operation Joseph, and underage sales work. We are aware of the messaging around vaping that is far more complex than that relating just to tobacco, due to the fact that it's often associated with providing safe alternatives. But the health effects of young people is still being studied, so there is an unknown there as well. We also know that the government are planning further controls that will come to the councils and that the Public Protection Services will be the service that will be implementing those controls. Delivery will prove challenging with additional targeted resource in all areas of trading standards that are currently under significant budgetary pressures. Thank you.
Thank you. Just anybody have any questions, or please? Joe.
Thank you. I don't think I have a question as such, but I'm glad to see that David Marsh has also put his hand up. So we didn't want to let you just walk away without having an opportunity to say a bit more. I think it's a really interesting paper. It's not a subject that I know very much about. So actually it was good to read this to give me a little bit more of an insight. And I know certainly I have friends that work in schools, in particular in secondary schools, where they quite often have to visit toilet areas during lessons to find vaping equipment that has been hidden, so that and apparently it's well known that somebody can go and they can use it and all sorts of other things. So it's scary from the point of view that some of our young people have designed these ways of being able to access them, even though they shouldn't be having them in the first place, but they're able to, via stealth, they're able to then share it amongst their peers and their friends. I think it's a huge worry. I'm pleased that, that agencies are doing something and thinking about it and what's going to, where it will all end up. I guess education is one of the key things. So all of the messages that need to go into education, I would absolutely wholeheartedly welcome. And in particular, I guess training for the staff, in particular for the teaching staff, so that they know what they're dealing with. But thank you for bringing this report to us.
Thank you. David Marsh.
Thanks, Chair. Just to say, as the parent of a 12-year-old child, I'm personally concerned about this as well as in the wider context. And I just wanted to mention that we did discuss this at the last meeting of West Berkshire Council's licensing committee. And we had some very interesting feedback from Sean Murphy, the officer, about what is being done across the PPP, and which was encouraging. And the members took quite an active interest in this and were keen that the authority should support that work. And he spoke about, for example, the anonymous going into shops and using young people to find out if vapes were being sold to underage customers, for example, that sort of thing. And he also made the point that, of course, there is more, perhaps a bit later than we might have liked. The government is actually doing something about this now, and including banning the disposable ones, which cause such environmental damage as well as health and welfare damage. So I think you can take it that members will continue to support that work and take an active interest in tackling this problem. And I would say the schools are doing that too. I can only speak about St Bart's, which is where my son attends, in Newbury, but they're very well aware of the problem, and I think they're on it. And as far as I'm aware, it's not a big problem at that school or other schools that I know about in my ward, but it's obviously going to be there, and it's something that we all need to be aware of. So thanks for the report, and I echo the points that Joe made as well.
Thank you,
Councillor.
I do have a question, actually. I was wondering if the service provides advice to shops, and I have in mind the co-op in Thiel, where the vapes were used to be just in front of the tobacco behind the counter, but a new display case has appeared, which is which is available in the main body of the shop, and it would be possible for people to shoplift those vapes. And also, of course, it's an added incentive to buy them. So I was wondering, do we provide advice on things like that?
Yeah, I mean, we would work with the trade, with retailers, as far as we can. We are very much focused on, I guess, the users at the moment, but we tend to be more enforcement minded for the retailers, but we certainly, given the opportunity and resourcing, we would certainly be able to work more closely with retailers and trade, because anecdotally, when we have engaged with them, they tend to be the smaller independent firms that are probably needing more support than the larger ones. And of course, there's a due diligence issue around the supply chain as well. So we do work with them. We do sort of, on a sort of ad hoc basis, but we could probably be more strategic around the whole retail arena, and which we hope to look at next year.
Oh, thank you. I had in mind that it wouldn't just be the co-op in the field that would be doing this. I imagine it'd be the same for the co-op convenience stores around the district. Thank you.
If I can come in just to talk a bit about this, because I know that it is a problem, and parents are quite worried about vaping in schools, and I'm a school governor as well, fairly locally. So I know that this does present an issue, but it's quite demanding on the teachers to be able to try and police this, if you like, in school time. And obviously when parents send their children into school, they expect them to be kept safe for that area of time while they're there. But it is an issue. So I know it would be good to share some ideas across schools that are tackling it effectively. Some have a sort of better searching device, because they can't search pupils, they can only search their bags. So if the pupils, they don't have to be too clever to work out if they tuck it in their trousers, it's probably not going to be found. So if they are able to use those sort of searching tools, almost like when you go through an airport sort of system, then they might be able to detect it on them, and then they would have to then get the pupil to volunteer it to them. But parents have to work hard as well. I think there should be some responsibility on them to make sure that their children are safe walking to and from school. They are parents, so they should be searching their children's rooms if they are concerned that they're using vapes, because it won't just be happening in school, it will be happening to and from. There is some work that we can do around schools, around the shops, that we are doing some test purchasing operations for, that we utilise our police cadets in terms of going to buy these. And they obviously are made to be and look very attractive, aren't they? And they are in all the sweet shops where the children used to go to buy their sweets, they now go to buy their vapes. I question how diligent the shop owners and keepers are being when they're selling those vapes, and how much they question the children. So good opportunities to try and put some test purchasing operations, I think, into effect, try and then keep the children safe. I think some information could get sent out to parents as well from schools around trying to have that sort of more robust approach to this. So then that will in turn help the demand on the schools. But it's interesting what you said, Joanne, about that device sort of being kept in the toilets. So I mean, schools are having to go to quite extreme measures, aren't they, by removing doors to toilets, which have always been sort of a safe space. But this is around almost policing them to keep the children safe from vapes. So I know it is a challenging area, but one that is concerning quite a lot of people in the community at the moment.
Thank you. My local secondary school had to reinstall all the doors a year or two ago because they had a strike, which is understandable, actually. I think, George, am I right in thinking that in the test purchases that training standards have done, I think there was only one shop that failed the test?
Yeah, so we do. So obviously, with enforcement of underage sales, that tends to be a covert operation with young people. And we did have one successful sales or a failure, but we also look at operations around product seizures. So we'll go into the shop, and if they're illegal vapes, that means they haven't come through the proper export channels, or import channels rather. We've seized those. We've done quite a number of seizures as part of Tan-Oak. The problem we've also got, and we haven't put it in the paper because we've just had results on it regarding Operation Joseph. So the products that are actually that are legitimately on for sale have to be certified by the healthcare agency. Those products we had tested as part of a national surveillance program, and the results have come back have been quite varied. There have been some failures in terms of excessive nicotine, for example, but there's also been some failures on product labelling where there has been quite a significant reduction in the amount of nicotine. So in essence, there's a technical labelling offence. So it's becoming quite a complex area, but we are certainly keen to build on our intelligence, work with our schools, work with the retailers, and to try and sort of fish out the rogue traders, rogue supply chains, and criminal activity.
Thank you very much. Thank you for your report. I'm sorry, excuse me. Could we move on then to item 15? Sorry. Janine has a question, sir.
Sorry, always the last one at the party. It's just to check the understanding of point number 7.5 on the paper, and you've used the word holistic approach. Does that mean that you're going into schools, perhaps with young people agencies? I can only think of the agency number 5 at the moment, but there are a few like Berkshire Young Youth, to role play the reasons why young people want to use the vapes, and then role play through the consequences of using the vapes, and then also involving the parents, because as you were saying about the parents, they don't often take accountability. They want somebody else to deal with it. But if people could understand the consequences, that could fit in with this holistic approach.
Sorry, yes. As I say, when we work with the schools, we are working. We put on productions and drama productions, but these tend to be aimed at the children. So there is an opportunity to work probably more closely with parents and schools. So we do welcome any ideas that anyone might have that will allow our officers to go out and engage better with all the stakeholders involved.
Thank you. April?
Just to say, it was a little while ago now, but with our previous Director of Public Health, Tracy Daskovich, and working with our schools and Paul Graham, who delivers our Healthy Schools programme, we did do a letter via the schools out to parents about the risks of vaping, but that was some time ago. So maybe that's something that we could rethink about, doing some further communication out to parents. So I'll take that away and speak to Paul. He may already have something underway, but I'll have a chat with Paul Graham about that and see whether that's something we could look at doing again.
Thank you. It's very helpful. Thank you. Any other questions or points?
Thank you, George. And it's just to make a point about vaping generally. It's being perceived and promoted as a safer alternative for nicotine smoking. But the scientific evidence is that if you are willing to stop, then it should be used as an interim measure. It's almost like a swap to stop. I don't think that message is clear out there at the moment. You know, I do look after a lot of patients and they do perceive it as a safer alternative, and adults and children model themselves on adults actually. So if we could get the message correctly, please, you know, that would be a useful adjunct. Thank you. Thank you, Chair.
Thank you. And any other points or issues? Thank you. Okay, so can we move on to item 15, which is the West of Berkshire Safeguarding Adults Board Annual Report. And I'm asking members that if they do have any concerns about anything in the report, could you bring them back to the next meeting, please? And move on to item 16, the subgroup updates. These are provided for information only, but if there's any issues that members would want to raise, could they do so, please? Thank you. We move on then to item 17, members' questions. And we have a question from Councillor Vicky Poole. Is she online? Councillor Poole is not online, so she'll receive a written answer. So, move on to item 18, the Oh, sorry, Joe. I've got blinkers. I can't.
No, sorry. There's a lot of noise around as well, so it's hard to hear. So would it be okay? I don't know if every other board member wants to see that response to the question, but I was actually approached last night at a meeting about it's about the Burfield pharmacy. And I would really like to know that response as well, so that I can go back to the individual that raised it with me. Would that be okay?
Yes.
Yeah, thank you.
Sorry, I forgot to turn my microphone. Yes. Move on to item 18, which is the forward plan. And do any members have any comments or suggestions for the forward plan, please? Heather.
Yes, would it be possible to add special educational needs and disabilities to the forward plan? We've got a new service director. We have interviews tomorrow for a new service director for education. Hopefully they would be in post in sort of 3 months or so. Could we put something on for September?
Is it just the topic in general, or
in general, and to bring it into health, so that it's actually joining up with education properly?
And there was this issue raised at the LGAPA challenge, wasn't there?
It's a big issue. Yep, absolutely. Not just for this council, but across the country. So.
I just complete what I said for people to understand that they were suggesting that the council should be more involved with the health service when it comes to commissioning services for children with special needs. Thank you. Yeah, members may be aware that there are 2 consultations underway at the moment related to the redevelopment of the Hampshire hospitals and the Royal Berkshire Hospital. I have been asked if the Health and Wellbeing Board wish to consider these and make a collective response. However, given the tight timescales involved in responding, and also potential conflicts of interest between some members of the board, I would suggest it might be more appropriate for each partner organisation to respond separately. Are members happy to proceed on that basis? Thank you. If members wish to find out more about the proposals, information is available on the Hampshire Together and Building Berkshire Together websites. Though I must admit I had difficulty finding the consultation on the Royal Berkshire website. There is an in-person listening event for the Hampshire hospitals taking place tomorrow between 1 and 3 p.m. at the Waterside Centre in Newbury. Members will also be aware that hot focus sessions are being arranged between meetings, provide the board with further opportunities to find out about the work of subgroups. The next session will be on the 6th of March and will focus on health inequalities. It's been suggested that the following hot focus session could be used to consider lessons from the recent PA challenge, might allow us to consider issues in more depth than we could in a public meeting. Are members happy to proceed on that basis? Sarah.
So I was just going to come in on the new hospital consultations. So the Hampshire hospitals is a full public consultation on the potential future configuration of the hospitals, including locations. The Royal Berkshire one at the moment is just a questionnaire to seek views on priorities and public kind of views on a range of questions that are in the questionnaire to do with the potential new hospital kind of arrangements. So it's not a full consultation, it's just a questionnaire. We're not at consultation stage yet for Royal Berks.
Well, thank you for that clarification. But the questionnaire does, I think an important thing to note is that they think there will be significant challenges on redeveloping the existing site. So they're proposing two alternative new sites to the east of Reading. So I think it's quite important for members of West Berkshire Council certainly to be able to respond to that, because that might make life more difficult for their residents. Thank you. Future meeting dates. The meetings for the remainder of this municipal year are on the 2nd of May. The dates for the next municipal year will be agreed at the annual meeting of the council in May. So thank you all for your attendance, and